Hi, Lilian. It's a pleasure to speak with you today. You and I were connected by a mutual friend and a colleague who I met at a conference in South Africa and again in Colombia. Most of the people I've interviewed so far have actually been personal contacts, so this is a nice opportunity to get to know someone new, though I've heard a lot of good things about you already. Your career spans more than 15 years across Kenya's health system, leading national cardiovascular and non-communicable disease (NCD) strategies, directing large-scale programs at Amref Health Africa and Kenya Cardiac Society, strengthening CVD guidelines and essential medicines policies, and guiding advocacy for NCD prioritization. You now serve as medical director at Cardi Hub, executive director at the Center for Cardiovascular Prevention and Rehabilitation, and consultant to the World Heart Federation, supporting curriculum development and secondary prevention tools for 3 African countries. Your work sits at the intersection of health system strengthening, evidence-based guidelines, digital health innovation, and global national partnerships. I'm so excited to learn today from your insights on cardiovascular health, NCD systems, and leadership across sectors.
Thanks. It's a pleasure to meet you, and I'm really honored for you to invite me for this interview.
Thank you. So my first question for you today is about your career path and motivation. You've worked across clinical care, HIV programs, NCD strategy, national CVD policy development, and now regional CVD prevention. What guided your transition towards focusing more on cardiovascular health and NCD systems like you are doing now?
Yeah, it's been an interesting journey. So, of course, I did my training in, a medical doctor, and then later public health. So, ever since, I've always had interest in lifestyle-related conditions, specifically like NCDs. But when I started my career, there wasn't much happening in our, country and continent on NCDs. A lot of the focus was on infectious diseases, HIV, TB, malaria, and there was a lot of, emphasis and funding around that space. So what I did, I actually got into a HIV program, and that's when I worked for the government for a few years, 2 years, but then I realized my interest was more on public health than clinical practice. So I moved to the NGO space, and the first opportunity I got was HIV, because that was what we were focusing on as a country and also globally. So I did work there, but then what I did, because I still had that interest in NCDs, I slowly kind of tried to find ways of bringing in NCDs. So at that time, the opportunity that was there was cervical cancer, because of that linkage between HIV and cervical cancer. So we came up with a program where we'd screen HIV, women who are HIV positive in the HIV program for cervical cancer. And, that was quite fulfilling, because I felt, wow, okay, now I'm starting to bring in NCDs into my career. And then later, we were fortunate as Amref to get a grant on hypertension awareness and screening. So then later I moved to running it was one of the first NCD large-scale projects in Kenya, I would say, and it's the one which kind of really opened up the NCD space in the country, because we're able to really do a very large-scale hypertension screening in different places in Kenya. I would refer these patients for treatment, and we did quite a bit of publication. So now I totally moved to NCDs, although still at that time there wasn't much funding. So after that program ended, and then I got again fortunate to transition to Kenya Cardiac Society. So I was the CEO of the National Cardiology Society for 5 years. And that's where I really now focused primarily on cardiovascular diseases. So that's kind of in a nutshell how I, really got into the NCD space.
Okay, thank you. I think those are good lessons, that sometimes you take the opportunity that's available to you, and everything in health right now is important, of course. And then you find ways to focus on your special interests. I have the same in my path. So my second question, oh, sorry.
Maybe just to add, I know like in global health, the principles are the same, whether you're in HIV, whether you're in TB, malaria. So, the experiences I got in HIV are quite very much translatable now to NCD. So as you're saying, I do agree. Sometimes you don't have to fix yourself to the specific thing you want. Sometimes you take what is available and then use that as an opportunity to, cross-learn across different programs.
So true. And I think they call that also transferable skills,
Exactly.
besides the overlapping topic
Yeah.
areas of knowledge.
Yeah.
My second question for you is about multi-country systems lessons. So through your work at the World Heart Federation and other partners, you've supported secondary prevention and capacity building efforts in Zambia, Mozambique, and the Democratic Republic of the Congo, DRC. What differences or similarities did you observe in how these countries approach CVD and broader NCD care?
Yeah, just to give a bit of a background. So while I was at Kenya Cardiac Society, we got fortunate to get some funding from World Heart Federation. Actually, that's where my involvement with the World Heart Federation started. So at that time, there was a lot of emphasis at WHF level on hypertension, and they had a specific interest in Kenya. And when they came to Kenya, to the Ministry of Health, Kenya Cardiac Society was one of the main partners in cardiovascular care. So we were brought in, and that's how WHF agreed to fund a project in Kenya where we were training health workers on cardiovascular disease management. Because of that experience that I got running that program, so I did run that program for about 4 years, and we were able to train health workers across different parts of the country on cardiovascular diseases. So again, when WHF partnered with one of their collaborators who had interest in secondary prevention, then my name came up because I had already experienced doing it in Kenya. And I'm saying this because these 4 countries are all low and middle income countries. So the challenges we are facing in the transition from infectious diseases to NCDs are very similar. Kenya is a bit ahead because we even have cardiovascular disease guidelines. We have quite a number of policies, but a lot of challenges, at the health facility level, at the population level, like awareness, are really similar. So it was quite a natural progression to now get into these other 3 countries. I had a lot of experience working with the Ministry of Health, which is very important if you really want any project to be successful. Engaging the policymakers, the Ministry of Health is really quite important. So using that experience, it was quite a natural progression again to get into these countries. And so I did transfer a lot of experience I had gathered in Kenya to those 3 countries. So that's really how I transitioned there. So I think what I'm saying is the fact that there were a lot of similarities in terms of how we approach programs in these 3 countries, the challenges, and I already had experience with that in Kenya. It was quite easy for me to get into that space as well. Of course, I wouldn't say it was scary because I was used to doing a project in one country which I was familiar with. I knew, most of the people were colleagues and friends, but then come to this new country. Of course, not everything is the same exact. So what we did, one of the things we did is we partnered with local institutions. So we identified local institutions in the 3 countries who we collaborate with because they understand the cultural differences, the policy differences, health system differences. So together with them now, they were able to, I was able to work with them to see how best to implement. So really, if you're doing a regional project, it's very important to see how to bring in the local team so that they can guide you, because again, we shouldn't assume that everything is the same because we are all African countries. There are differences here and there, and working with a local team will really help to make sure you don't make assumptions on some things.
That's such a good lesson for anyone learning about global health to have reinforced that you can't do anything without the people who the issues are affecting and who know the country better than anyone else from the outside could. But also there's, for example, some very simple differences like language. In Mozambique, it's
Exactly.
Portuguese, DRC, French.
Yeah.
So
I didn't mention that, but that was another challenge which I had to overcome. But again, the good thing is getting, at least in all the two countries where the language is different, we still have English. In the team we identified, we have people who speak English. So they are able to really support that during our meetings, they're able to support that translation of language. And then what we did is, again, because we're working with local partners, whenever we have to engage health workers or the Ministry of Health, they are able to communicate directly with them in the local language. So again, very important to work with local institutions.
yeah. My next question for you, thank you, is about guidelines and evidence translation. So you've contributed to Kenya's National Cardiovascular Disease Guidelines, Universal Healthcare Benefits Package, and Essential Medicines List updates. What have you learned about the process of adapting global evidence to local contexts so that frontline providers, healthcare providers, can realistically implement guidelines?
Yeah, that's really a very important thing that for me I've come to learn firsthand. So of course, many guidelines, including international guidelines, are based on data from other, from those areas. And unfortunately, because we don't have a lot of research and local data, we have to rely on the international guidelines, and that's what we do. But what we do, we sit down, go through the guidelines, and just make sure whatever we are now recommending in our local guideline is context sensitive. So that's the first thing is, as much as you don't have local data to inform your own guidelines, you have to sit down and really look at those international guidelines and make sure that they, whatever you put into your local guideline is relevant. But I would still want to emphasize that really we are now really doing our best, especially as Kenya Cardiac Society, to generate our own data, because we realize we're actually not the same. For example, NCDs in our setting happen almost 1 or 2 decades earlier. So our patients are getting NCDs in their 40s, in their 50s. I think in other settings, it's much older. So you see that already is something that's different. And there are many other things, even simple things like hypertension medication. What works in our population, we found is not the same. So for now, yes, we rely heavily on international guidelines, but definitely, you must sit down and either generate your own data or adapt whatever international guidelines are there to your local setting. So that's very important. The other thing is, for example, in the universal health coverage, of course, issues of resources. So we don't really have an unlimited resources. So basically, a benefit package is a package of care you want to offer to everybody in the population. And for you to do that, you have to then go through a process of selection and say, these are the basic things that everybody must access. And in that process, some things will be left out at the beginning and probably added eventually. So the guidelines, benefit packages, the essential medicines have to relate with the resources that are available in the country. So that's usually a very big consideration when guidelines and all these benefit packages are being developed. They have to be fit within the pocket of funds that are available from the government. Yeah.
Yes. Yeah, I just want to highlight like 2 themes I heard. The first one was the importance of data, and something that other people I've talked with in these interviews have recommended in terms of a skill that students can develop now, especially as global health as a field is in transition, is hard data skills, data analytics and understanding. And it's hard to do anything that's context specific, like you're saying, without real data, understanding that data or how to collect that data, how to analyze it. So that's a really good highlight. And then the second thing you said about realistic resources, making programs that have all the resources in place to be able to support sustainably going forward. So
yeah.
yeah,
So maybe
thanks for those
one more
points.
thing I would say is, so there's data, collecting just data on to understand the burden of disease, to understand how the different conditions present, what are the risk factors and all that. But there's also data and research on translating evidence into practice. I think we all know there's a gap. We have guidelines, but they're not being implemented. So also we need research to see how best to translate available guidelines into practice, day-to-day practice.
Yes, yeah, definitely. Thank you. So my next question for you is on primary care and integration of NCD services. Much of your work has focused on integrating hypertension, diabetes, and CVD care into primary health systems. What have been the biggest barriers and the most promising strategies for strengthening NCD services within PHC, excuse me, primary healthcare? I try to say all the acronyms in case the students don't know them, so sorry.
Yeah. So of course, for us and for many African countries, primary healthcare is really big focus now, because that's the only way we're going to get universal health coverage, is by strengthening the primary healthcare. And the biggest challenge is that the primary healthcare many times is not well resourced. And what I mean is, many times, there's not enough health workers, or they are not, adequately trained. We don't have medical supplies, and even if they're there are shortages. So they are on and off the medical supplies, diagnostic equipment, simple things like even HbA1c, ECG machines, at times even functional BP machines. So the biggest gap is the primary healthcare just needs to be well resourced. That's the first thing. It needs to be strengthened so that it can be able to manage NCDs. And remember, we are still dealing with infectious diseases. So the previous, the current private healthcare system is really designed for acute care. For a long time, it's been, how it's been structured is to manage acute conditions like malaria and, TB and other infections. So now NCDs are different in many ways. First, lifestyle is a huge part of it. So there's a big component of prevention that goes with NCDs. And because our health systems are mainly curative, just give medicines, we haven't been doing a lot of health promotion, a lot of education. So introducing that aspect it's a challenge, because it needs not just resources, but a mind shift for the clinicians and the health workers to make them know that it's not just about doing lab tests and giving medicines, but for NCDs, lifestyle advice is huge as an intervention. So that's a whole challenge that we're having to deal with, how to deliver lifestyle interventions at the PhD level, who should do it, what capacity and all that. And then secondly is NCDs usually need long-term follow-up. I've just told you that our systems are designed for acute care. So you're having now patients who have to keep coming back to the facility, maybe every 1 month, every 2 months, every 3 months. So having systems to track these patients over time, make sure they stay on medication. So again, putting in place systems for chronic care, not just at the facility, but even at the community level. And many times you need data systems which are able to track this patient longitudinally. You have to follow up this patient. It's not like malaria. Once I treat you for malaria and you're cured, that's it. But this hypertension patient, I need to make sure they're coming back to the clinic. Otherwise, then I don't know if they're getting controlled. So prevention and putting in place systems for longitudinal care, and then just generally the primary healthcare just needs to be well funded so that it can be able to support both NCDs and the ongoing communicable conditions.
Yeah, some of the same themes from the last question about like sustainability, long-term planning for the system, and making sure it's well resourced.
And prevention.
So, and prevention.
It's huge.
Always prevention, public health. Yeah.
Yeah.
True. Thank you. My next question for you is about digital health and innovation, bringing in some new technologies. You've helped design hybrid cardiac rehabilitation models and explore digital tools for patient education and follow-up. What role do you see digital health playing in improving access and adherence for people living with cardiovascular disease?
Yeah, so maybe just to mention how I transitioned to cardiac rehabilitation. So while I was in KCS, I did some studies on preventive cardiovascular medicine, and I came across cardiac rehabilitation, and I realized it's something that we don't have in Kenya and most of Africa, and so I've been dedicating part of my work to improve access to cardiac rehabilitation, and within that work, I have been using digital tools. So because the traditional cardiac rehab approach is people to come to a clinic every so often, but it has had challenges. So for us, we are doing a hybrid model where the patients come in once in a while, but we're able to follow them up at home. And of course, we use digital tools. So I've also used digital tools in follow-up of patients, for example, with hypertension. We did a study where we used an app, a mobile app, where patients were able to put their BP machines while at home, and it showed that there was improved adherence and knowledge. But what I can say is, in our setting, the challenge we've had with digital tools is sustainability. So a lot of programs which have come to test and implement digital tools have shown good results, but it's been a challenge to get the government to take up and fund some of these digital tools and innovation. So yeah, it really needs a lot of advocacy, a lot of maybe research around cost effectiveness to convince the payers, the policymakers, that this tool is going to improve this, or is going to give these outcomes, is going to be cost effective. So I think that demonstrating how those digital tools are going to improve outcomes and they're going to be cost effective is an element that we need to think about. And also, I think digital tools, so if your services and your system is weak, I don't think digital tools are the magic bullet. That's what people think. Let's plant a digital innovation into this health system and we're going to solve everything. But I think the system just has to have a certain level of resources already. It needs to have some systems in place already. And then the digital tools are now coming to kind of strengthen and facilitate or amplify whatever is happening. So I think for our setting, we should not just get excited with AI and all these digital tools. They're good, but we need to just remember that this needs to be embedded into a health system that's already strong. So that's, I think, what I would say about my experience with digital tools.
Thank you. Next question for you is about partnerships and advocacy. So you've worked with, let's see, Amref Health Africa, the Kenya Cardiac Society, the World Heart Federation, the Pan-African Society of Cardiology, the Kenya Ministry of Health. What have these very diverse partnerships taught you about what makes collaboration effective in advancing specifically cardiovascular and non-communicable disease practices?
Yeah, that's a loaded question. But, so,
or maybe what harms collaboration as well, not just what makes it effective. Sorry.
So I think what comes at the top of my mind is trust. I think it's really important at the beginning of any collaboration that trust is built. Of course, trust is built from it's earned, and it's earned through already working together, and people see that, yeah, this is a partner who is looking for our interest, and therefore we can trust them. So I think trust is really the foundation of partnerships. So you have to strive to reach a place where trust is built and confidence, and that way the collaboration is really working towards a win-win situation for both parties. So building trust, again, finding value for both partners. So for any partner you work with, you have to think about what is the value for each of the partners involved, because everybody has something they're trying to achieve. And so how do we together achieve this objective? So if I enter into a collaboration and I don't feel, I feel like, more being used than, my objectives being met, then that's a big challenge. Maybe I can focus on the Ministry of Health. So for me, the successful projects that we've had with the Ministry of Health are those which are aligned to the ministry's priorities. So whenever you have a project and you want to take it to a certain country, or it's very important to go through the strategies of the priorities of whether it's a strategic plan for that country, and see how to link your intervention with a priority area for that country, and if possible, embed it into whatever is already happening. I'll give an example, like the World Heart Federation project, which I talked about, which was on the cardiovascular disease trainings. So the Ministry of Health in Kenya had already come up with cardiovascular disease guidelines, but they were sitting at the Ministry of Health because they didn't really have funding to train health workers. So WHO came and saw, okay, WHO, of course, their mandate is to improve cardiovascular care. So what the project we did was working with the ministry and telling them that we are going to train health workers, and we are going to disseminate this cardiovascular guideline that you have already developed. So you can see that it was really a win-win situation. And whenever we had future, and that built trust. So that was like a foundation of trust. And moving forward, WHO really had a very good collaboration with the Ministry of Health, because they already saw that this is a partner who wants to advance our agenda as well. So I think really for the ministry, finding and aligning with the country priorities is really very important. Yeah. And what else can I say? I'll say, yeah, collaboration in global health is key. I don't think, at this point, it makes any sense to try and do anything on your own. It's always good to bring in partners who can help. You can synergize with, learn from, and just expand your work.
Yes, thank you. Overarching lesson again. And the last question is about advice for students and emerging practitioners, anyone interested in the field. So looking across your diverse roles in leadership, research, guideline development, and system strengthening, what key advice would you give students who want to work in non-communicable diseases, cardiovascular prevention, or health systems in low resource settings?
So I think I would say you need to identify an area which you're passionate about. And it may not be the same throughout, but I think you need to have a broad idea of a direction that you want to head towards. You may not start with it immediately, but always put it at the back of your mind. I find it helps when you have that, because you will be able now to identify and form linkages of how you can get to that area. So, because for me, I always had an interest in NCDs and lifestyle, anything that would involve prevention of lifestyle diseases. And I may not have started with it, but just having it at the back of my mind and being consistently working towards in that direction really helped, because as I told you, there was not much funding. It was easy to be discouraged and say, okay, this NCDs, let me put it aside, let me move and do HIV or maternal and child health. But I think just, if possible, try and get into a certain direction and just be consistent on it, keep going, get mentors. Of course, you have to identify mentors in your space who you can keep in touch with, who can advise you once in a while. And also, when people see that you're consistent and you deliver, mentors also bring themselves. So I've had mentors I didn't even imagine. I didn't necessarily have to approach, but because they saw the kind of work you're doing, the passion you have with your work, the consistency, then they actually were drawn towards supporting you and getting you to, you know, grow your career. So I think that's what I'll probably say. Just be focused, try and be consistent in a specific space, and yeah, find people who can help you get to where you want to be.
Mm-hmm. Yeah, great. Thank you. Thank you for highlighting mentorship too.
And also, I think, yeah, education is important. So for me, when I just, you know, in whatever area you decide you want, just you get whatever kind of academic, you know, education that could help. Because for me, doing the preventive cardiovascular medicine really opened my eyes and made me realize exactly what or some of the interest areas that I'd want to focus on. So yeah, I also find, you know, or academic or research opportunities that can help you in your area.
Definitely. Well, thank you so much for your time. And I think this has been a great different perspective because I've talked to a lot of people in the HIV and sexual reproductive health space because that's more my background. So I'm so grateful for you adding this important information about NCDs and cardiovascular health and everything else you said so much. So I appreciate you and thank you for sharing your experience.
No, thanks so much for inviting me, and I hope this helps somebody. Yeah, and yeah, looking forward to keeping in touch.
Thank you.